My name is Kevin Severino. I'm an associate clinical professor with the Yale University School of Medicine and as well president-elect for the American Academy of Addiction Psychiatry. My disclosures for today: I have no financial relationships with any ACCME defined commercial interest relevant to the content of this presentation. The content of this activity will not include today any off-label recommendations for use of medications. Our target audience, the overarching goal of PCSS-MAT is to make available the most effective medication-assisted treatment to serve our patients in a variety of settings, including primary care, psychiatric care, and pain management settings. Our objectives for today in this presentation are that at the conclusion of the session, participants should be able to first discuss clinical issues in performing urine drug testing, which we'll refer to here on in as UDT, describe the basic types of UDT and when they should be used. Third, define the metabolism of opioids and benzodiazepines in order to interpret UDT results. And finally, describe other non-urine laboratory testing used as part of substance use disorder evaluations. And our outline pretty much breaks down the same way. We're going to be talking today about the purpose and use of UDT, the types of urine drug testing, the interpretation of UDT, forensic issues in UDT, and then again, other lab testing. First, let's talk about a case vignette. It always makes it more interesting. In the following, we'll meet Bill, a patient you maintain on buprenorphine naloxone. He provides a urine drug screen positive for opiates and buprenorphine. And we'll discuss how to interpret this result, as well as other aspects of the case moving forward. So first, let's talk about the purpose and use of urine drug testing. I would like to point out first a very key resource that was released in 2017 is called The Appropriate Use of Drug Testing in Clinical Addiction Medicine, released by the American Society of Addiction Medicine, ASAM. It's an excellent summary of this topic, and I'd urge all of you to get a copy of that to have it by your side, because it can go into some more detail than we can in our 45 or so minutes here today. So the goals of urine drug testing, the main thing I want to emphasize, it's not meant to be punitive. It's really meant to improve patient care and safety. It can facilitate the doctor-patient communication, because you and the patient both know you have the same information about what might have been consumed. It can provide objective information. It confirms or can confirm the use of prescribed medication. So it's being used for adherence testing. And then it can confirm the lack of use of non-prescribed medications or illicit drugs. And in the legal forum, it can be used as a condition of parole and probation. It can be used in custody and parental issues, and it can be used in workplace testing. What do we study when we do urine drug testing? The choice of matrix. Urine is by far the most widely used. Its typical window of detection is hours to days, with some exceptions that I'll point out, such as cannabinoids. The advantage is it's a very mature technology. Many labs are doing it. It's low cost. It has a nice, it's fairly easy to collect, and you can perform point of care testing that is right in your office. The disadvantages are that there are many ways to tamper with the sample before it reaches you. There's substitution, dilution. They may take a substance and adulterate the sample, called in vivo adulteration, or they may add something after the fact. And if you need to do a confirmation, which we'll discuss on it, with gas chromatography and then mass spec, that becomes more expensive. There is a debate in the field about whether the collection of the urine should be observed or unobserved. Many in the field would feel that they pretty much always have to be observed to be valid, but then there are others that say that that violates patient rights and privacy, and that in fact what you should do is only observe them when you have cause. And of course, there are issues of those that have been exposed to trauma in the past, where observing the urine might be more difficult or even traumatic for the patient. There are ways to, which we'll discuss, to get around the idea that somebody can adulterate the urine. You can normalize the results to creatinine in the urine, to its temperature, to specific gravity. You can look at its pH. You can look at levels of IgG. And then there are even special testing for adulterants such as bleach. There are other choices of matrix, however, which are being developed. Of course, in the field for police work, breath would be a very good detection method. Things are more rapidly metabolized usually, and so you've got a minutes to hours detection. This is most widely used as a point of care test for ethanol. Its use is expanding, but there are volume effects and contaminant effects. The next most common matrix that is used is blood testing. The window of detection there is usually minutes to hours. It's obviously more invasive. It's usually used in emergency rooms or for forensic testing, and it is more costly. Another matrix is oral fluid, mainly saliva. Here, the window of detection can really vary. It's minutes to days. It's very unobtrusive. It's easy to observe, and it's easy to collect. But there's usually poor sensitivity here. There are higher cutoffs to get specificity than for urine, and especially for marijuana. And it can be prone to contamination by foodstuffs, drinks, etc. Sweat is another matrix. Its windows of detection is hours to weeks. It is more resistant to cheating. It's collected over time with a patch, but the patch may fall off, and it's only prospective. In other words, you're collecting from the point you apply the patch forward. And then hair or nails has the longest window of detection because hair and nails grow the slowest. There, it's weeks to months. It's difficult to adulterate because basically you snip the hair off or the nail. It's directly observed, but the sensitivity is poor for marijuana. And then, believe it or not, there's hair bias. The darker the hair, the higher the cutoffs need to be. And there may be treatments such as Flamisil, which can affect the results. Practical issues for urine drug testing, especially those that plan on doing them in their office. First question you need to ask, are you going to send the specimens off to another laboratory? Or you may work in a hospital where there is automatically a lab set up. Or are you going to do the point of care testing in your office? Then it's whether the next big question, which is emphasized in the ASAM guidelines, is whether the testing is random versus scheduled. So many clinics, for example, a buprenorphine clinic, a tobacco clinic, will have a set time where somebody comes in and gets their buprenorphine, and therefore, by definition, a collection at that time would be scheduled. And the difficulty may be that somebody could then time their use of a substance so that during the window that the collection is made, they come up with no unexpected results. Random scheduling is much preferred, but is harder to manage in your clinic or your office. Again, the issue of whether these are observed or non-observed collections. And then finally, what I'll talk about at the end of this presentation is the importance when it's considered a forensically or legally valid measurement to maintain what's called a chain of custody of the sample. How do we discuss urine drug testing with our patients? With a new patient where you're initiating treatment, it usually can be part of your treatment agreement. I'll usually say this is our routine practice. We do this almost as a universal precaution. And it's a patient safety issue. For me to prescribe a medication to you, I need to know what else you might be using. It's also important to realize you're actually doing it to follow whether treatment's working, because in the patient's best interest, if somebody is not able to achieve the result you'd want, usually that's sobriety, then you need to change the treatment plan for that patient. And it is increasingly becoming consistent with standards of care. If a patient's been in treatment for a while and now you're instituting urine drug testing, you're going to get the question, why now? This was always fine before where we didn't do it. You might cite more current guidelines or guidance such as in the ASAM criteria where it really recommends that this be done, and let them know that it's going to be applied universally across the board for all patients and not just some. If the patient says, but I'm not a drug addict, and this is often the case in pain clinics, again, it's important to say that this is routine testing. It's not singling anyone out, but it's meant A, to determine the adequacy of the treatment, and B, to make sure that it's safe to continue prescribing whatever you're prescribing. If the patient says, I refuse, you might, and I often would say, I can't prescribe certain medications if I'm unable to routinely, safely monitor you. And it's then good to go back and emphasize that you're not using this to judge the patient or to punish the patient, but to treat, if you're treating addiction, to treat that as a disease and to be able to understand its course. As I said, you can test the validity of collected urine samples. There are even cups that are made now with a strip along the side, which will measure the pH, measure the temperature. And then there are some crude ways of doing it. If the sample feels cold in your hand, you might question the validity of that sample. If you shake it and there's no foaming at all, then you also question whether there's much protein in there at all. Most labs will actually look at pH, and they'll look at level of creatinine. Usually greater than 20 mg per deciliter is considered a normal clearance into the urine, though there can be some variation with that. If a patient needs to drink a great deal of water to try to give you a sample, the sample is going to come out more dilute, and that sometimes can be a clinical issue. So what's important to understand about levels of urine drug testing are there's a first level, there's a screening level, which is mainly based on immunologics, mainly an enzyme-mediated immunoassay. There's an antigen that's in the urine. It may be, say, a metabolite of cocaine, or it may actually be the opiate molecule. And antibody then reacts to that, and then that's amplified by a second antibody or fluorescent agent or something else, amplifying the signal. So anywhere where there can be immunologic cross-reaction, you can get what's called a false positive. And anywhere there would be something that would interfere with the antibody-antigen interaction, such as a gross change in pH, you might get a false negative. So you can, these can be in, they're usually dipsticks, which you put in, and then you see whether a band either disappears or turns black, or various other colors. If there are unexpected findings in that, we'll go into this in more detail, then you need to do confirmatory testing, because the antibody is prone to cross reactions. So confirmatory testing is first using gas chromatography, which may fractionate things largely on the basis of charge plus mass, and then mass spectrometry, which bombards the various fractions of the gas chromatograph and gives you a defined molecular fingerprint. So this is absolutely specific for what substance is in the sample, and there's no false positive or false negative. There's only interpretations of levels. The requirements for in-office urine drug testing, a practical point is that you must obtain what's called a certificate of waiver through the U.S. Department of Health and Human Services website, and you can go online to look for that. That's called a CLIA waiver, and why that's important is because CLIA is the Clinical Laboratory Improvements Amendments. It's a legal definition of what a test is, both accurate and that the people administering it are qualified to do that. So if you get a CLIA waiver, that says that your office is qualified to perform whatever test you want to. Most of the tests we have can be what's called a CLIA waiver test. These are tests that are demonstrated by the manufacturer to be accurate and low risk, even when administered and used by untrained personnel, usually the ones that are approved for home use. So if you have that, then the CLIA waiver clearly covers you. But even if you have an in-office fluorometer or other reader of urine drug tests, you can get a CLIA waiver to allow you to use that. The CMS will allow billing for a single test per patient encounter, not the number of tests. And I've been with the VA, so actually I'm not familiar with the actual coding, but a usual code is GO 477 for each unit. There is some controversy in people overusing these tests multiple times. We'll talk a bit more about the appropriate frequency of the testing in a bit. The other important thing to remember about urine drug testing is it's part of somebody's protected health information, and specifically, specially protected health information that involves one's possible diagnosis of a substance use disorder. So the Comprehensive Alcohol Abuse and Alcoholism Prevention, Treatment, and Rehab Act of 1970, and then later on the Act of 1972, established the Code of Federal Regulations 42, Title II, for special protections for those with alcohol use disorders, substance use disorders, HIV, and sickle cell anemia. That information that would reveal people had those is specially protected and requires a release of information that specifically states that that information is to be released. These guidelines were revised, or this code was revised in January 13th, 2017, to be more specific about that you not only have to specify the release, what's being released, but specifically to who it's being released and for how long. It also actually made it a little easier to allow release of this information to entities that are performing research so that it would not preclude the ability to do research. And as I said, the revision is meant to improve the dissemination of data for research, but better protecting privacy. So that's important to know, that if somebody calls you and wants to know their urine drug testing, make sure you have the appropriate release of information for that. So in summary, in our first part of urine drug testing, urine is by far the most widely used matrix. The decisions that in urine drug testing include whether you're going to use point of care testing or whether you're going to send it out, whether the collection is observed or random, and that whether you're going to maintain a formal chain of custody. Remember, UDT results are protected by CFR 42 Part 2, including the revision. It's important to discuss UDT with the patient as not only a constructive part of his care, but as a universal precaution, and that UDT has two steps, a screening step and a confirmation step. So what are the types and interpretation of urine drug testing? It's our second part. So as I said, the screening part of urine drug testing is by immunoassay. And there are these various types: EMIT, CODI, fluorescence polarized immunoassay. The bottom line is that they're all based on antibody-antigen interaction. They're widely available and cost-effective, and they're very well understood, but they are prone to cross reactions and false positives, and as well in some cases, false negatives. So common false positives. I think it's most important to realize that there's local variation in what these are. So always read the package inserts if you're doing point of care testing for the list of common cross reactants they're aware of. Otherwise, you can call your lab and find out what they have more commonly seen as cross reactants. And a more inclusive list I have down here, referenced by Muller from Mayo Clinic Proceedings. So for amphetamines, are by far the one with the most common false positives, commonly bupropion, dazipamine, Sudafed, ranitidine, and trazodone can trigger false positives. For benzodiazepines, and Zoloft is not uncommon, sertraline, cannabinoids, it can be some of the anti-HIV drugs, and NSAIDs and PPIs. Cocaine is pretty uncommon because it's actually a measurement of benzyl ecogmine, which is a metabolite of cocaine, and so very rare to get a false positive. For ETGs, some of the initial screens will be triggered by isopropyl alcohol, rubbing alcohol. Mouthwashes can actually have real ethanol in them, as can NyQuil. Opioids, dextromethorphan, diphenhydramine, rifampin, poppy seeds, which we'll talk about, and quinine, and then PCP again, dextromethorphan, diphenhydramine, tramadol, venlafaxine, imipramine, and ketamine. Urine testing for ethanol exposure is becoming more widespread over the last 5 years. Up till then, people were using breathalyzers only. And the problem with breathalyzer testing is it's really got a window mainly of hours. So somebody could have consumed the night before and you would miss it. With a cutoff of about 100 nanograms per mil, looking for ethylglucuronide, which is a metabolite for alcohol, and then ethyl sulfate, a more specific metabolite the window is 3 to 5 days post-use. We won't talk about blood testing today, which can also look at something called PETH, which has a window of 2 to 3 weeks. The testing is very sensitive, but it's not very quantitative. In other words, it's very dependent on how much was drunk and when it was drunk. So if you have 2 beers 3 hours before the testing, you may get a very high result. Whereas if you had an entire bottle of vodka 3 days before, you may there get a low result. The positives, as I said, can come from any source, real source of alcohol, such as cooking wine, hair products, mouthwashes, and hand sanitizers. So it's important to be aware of those. When the result of a drug test, your initial drug screen, is either 1, contested, 2, guiding a change in clinical decision making, or 3, done for forensic purposes, then you've got to take that first immunoassay screening and confirm it with gas chromatography mass spec, or sometimes straight liquid chromatography mass spec. So what are, and we'll talk about those in a bit. The cutoffs are a bit different for the two. You can see here what we used to call the federal or SAMHSA 5, the initial things usually involved in screening for THC, for pot, BEG for cocaine, opiates, PCP, and amphetamines. These cutoffs were initially, they've been modified because what you want to do is you want to have the best sensitivity, that is pick up the most real true positives, and the best specificity, that is eliminate false positives. So actually the opiate cutoff has been usually reduced in most labs to 300. So what is it we detect? Well, the natural opioids, the opiates, include codeine and morphine. These are well detected by standard opioid screens. The next level of only partial detection are the semi-synthetic opiates, hydrocodone and hydromorphone, which are modified from the synthetics. They're less well detected and usually require that you order a special test for them. Mandatory guidelines for federal workplace drug testing last year made them part of a standard screen for federal workplace testing. The semi-synthetic opioid that's very common, oxycodone, and its metabolite turns out not to be well detected. And so most screens now include them as a separate test. But at high levels, something like oxycodone will trip the standard opiate screen. And then finally, the full synthetics, methadone, buprenorphine, fentanyl, meperidine, are not detected by a regular opioid screen, and they'll require separate tests. And many places now automatically include methadone and fentanyl in their screens. It's important to understand opioid metabolism to interpret a urine drug test for opioids. So for example, if you found, so heroin goes through 6 MAM, 6 monoacetyl morphine, 2 morphine. If you see 6 MAM in your GC mass spec confirmation, that's pathognomonic that that subject's been exposed to heroin. Codeine also breaks down to hydrocodone, but also morphine. Morphine's the longest acting intermediate in this breakdown. So many times in your confirmatory testing of an opiate positive urine, you will see morphine only. That means they could have been exposed to heroin, they could have been exposed to codeine, they could have been exposed actually to morphine, which is not very commonly used anymore. And because poppy seeds can actually be contaminated by opium milk, sometimes if eaten enough, they could have been exposed to poppy seeds. So that's not just an urban legend. But let's say you found hydrocodone and hydromorphone. That usually would be indicative that both morphine and codeine had been ingested. Or you saw just codeine and hydrocodone. That wouldn't mean that they took Vicodin. It meant that they took codeine and as well could have used Vicodin. Oxycodone does not go to any of those metabolites. It goes straight to oxymorphone and noroxymorphone, and as well noroxycodone. So let's use an example here of our thinking with this. If we had a enzyme immunoassay that initially showed up as positive for oxycodone and positive for opiates, you then would need to do a confirmatory test to try to determine what opioids those involve. So if oxycodone is present in a high enough amount, it would trigger opiates. But if not, it could be another substance. So you do your GC-MAT spec, and you find only oxycodone and oxymorphone. And what does that mean? If you go back to your little chart here, we've got oxycodone and oxymorphone, which is consistent with only oxycodone having been ingested or used by that subject. Benzodiazepines, it's also important to know their metabolism. Clonazepam and lorazepam are not well detected in my labs. Usually 0.5 mg BID of clonazepam does not trigger a positive result. And confirmatory testing is often needed to identify the specific metabolites for a positive screen or to confirm the absence of metabolites. So for example, if clonazepam comes back negative and you are prescribing that person a low dose of clonazepam, you can do GC-MAT spec to confirm that there are levels of clonazepam and its metabolite there, but they just don't trip the enzyme immunoassay screen. This is another diagram you may want to post up. You can see that many of the benzodiazepines have simple metabolism. Clonazepam to 7-aminoclonazepam, alprazolam to alpha-hydroxyalprazolam, and lorazepam to lorazepam glucuronide. But the most complicated one is Valium diazepam. Diazepam not only can break down to nordiazepam, which can then go to oxazepam, but it can go through temazepam as well. So if somebody is taking diazepam and you do GC-MAT spec, you may find all three: diazepam, temazepam, and oxazepam. So it would be important to if you were prescribing them Valium, not to misinterpret this to mean they were also using other agents. Chlordiazepoxide also goes to oxazepam, Xerox. Typical detection times for detecting somebody's exposure to a substance, you can see that tetrahydrocannabinol, because it is lipophilic, a single use can be still positive to 5 days or under, and that chronic use can be positive for a month or less. Cocaine is usually 3 days or less. Opiates can really vary depending on whether it's a long-acting opiate or short-acting opiate, whether they're exposed to high dose or low dose. 6 hours to 3 days is typical. PCP, again, can be 8 days or less, but 30 days for chronic, and amphetamines are fairly short-acting, short-lived in the urine at -3 days. And then this looks at some of the common opioid and benzos broken down. If, for example, the longest acting opioid we have here is methadone, you can see it can be positive out to 11 days. Oxycodone, on the other hand, just to 3 days. Diazepam, as you saw, it has the most complicated metabolism or catabolism, and that can be positive for out to 21 days, very long acting. And that's why it's a bit difficult if somebody uses that for alcohol detox to then follow them to make sure they're not using something else. Lorazepam and alprazolam, which are short acting, 2 and 3 days. So summary to our second part. Urine drug testing begins with an immunoassay-based screening. Always remember that to confirm the result, you need GC-MAT spec confirmation. False positives are most common for amphetamines, least common for cocaine. ETG and ETS testing for alcohol is coming into wider use, and I think it has helped us. And then to understand the catabolism of especially the opioids and the benzodiazepines helps us to accurately interpret GC-MAT spec results, the confirmatory step. A few words about forensic issues, which only some of you will be involved with, but it is important to understand. The federal government regulates urine drug testing for just a select group of people, employees, federal employees, and then public and private sector employees that work in the transportation and pipeline industries. And then finally, all other drug testing is regulated by the state. Only about half have specific drug testing statutes. I should also point out that an employer, in terms of short-term disability or long-term disability plans or workers' comp can also attempt to define requirements for urine drug testing as well. Requirements for a valid forensic collection. So, for example, for the federal workforce. And you can see this is pretty complicated. You need appropriate collection sites that are approved. You need trained collection personnel. You need to inspect the sample immediately after the collection. And then we're going to have what's called a logbook at every step of the way. There are initials or signatures there. The specimen must be collected in view of the testee and the collector at all times, and then it's labeled, and the testee needs to confirm the label. You immediately record some field testing, which is mainly temperature and pH, and then finally you complete the logbook. And the testee also signs this. So you can see that most of the time in the clinic, we're not following those kind of rules. So then what you have is a chain of custody form. The collector completes the CCF. You must have an approved secure place to store it. You must use colored toilet water to make sure they can't adulterate the sample with it. And any handling or transfer of the sample, so for example, to somebody that carries it down to the car that's going to transport it, to the person that's in the car driving, to the person that then hands it off to the lab person, all of those have to have signed transfers. And the container must be sealed with tape, signed and packaged, and approved for transportation to a certified lab. So you can see that it's quite important to have an established chain of custody if you're going to do forensically valid collections. Interestingly, many probation officers don't require that from clinical programs. What is a medical review officer? The important thing about these samples is their results must then be reviewed by a medical review officer, an MRO. These are largely established by regulations in 2001. A licensed physician must have clinical experience in substance use disorders, take a training course every 3 years, and then be certified by the MRO Coordinating Council or the AAMRO. What does he do? If a sample is negative, he signs off that the specimen was in expected parameters, usually temperature and pH, not temperature and creatinine, and that the custody of control form is up to snuff. If it's positive, he makes sure that that result was confirmed by confirmatory testing, that the cutoffs were correct in that confirmatory testing. And interestingly, if the sample had been considered invalid, that is, the cutoffs were wrong or there were other procedural issues, it is called test canceled. They don't give the results out to whoever is asking for the results, and the test is immediately reordered. If the sample is adulterated, in the MRO's opinion, the results are not released, but is put down as refusal to test, which could be grounds for termination. And for example, if somebody is on Adderall and it comes back positive for an amphetamine, it's being used under prescribed conditions. It's not reported as amphetamine positive explained, it's reported as negative so that you protect the information of the employee. So in summary of this part, the federal government regulates urine drug testing for only certain classes of employees. A chain of custody requirements are very specific and must be followed. And an MRO provides the interpretation of the results to protect the validity of the result and to protect the testee. And finally, let's talk about other lab testing. And I'm mainly talking about other blood work that you may obtain in terms of the substance abuse evaluation. You can do this for diagnosis because remember, a single urine drug tox does not necessarily tell you that something's been used chronically or that has been resulting in an adverse medical condition. You may use it for treatment monitoring. You may use it for detection of physical sequelae and detection of comorbidity, which as a substance use as somebody treating substance use disorders, we're in a unique position to actually identify comorbidity and try to guide somebody to treatment, such as convincing them to stop smoking or convincing them to get Hep C treated, etc. So other lab testing other than urine or urine drug testing is meant to complement the H&P. For chronic alcohol use, You might find macrocytosis, you might find anemia, you might find thrombocytopenia. Biomarkers are not often used. The least specific are GGT and LFTs, and the classic pattern is SGOT or AST, 2 times greater than SGPT, otherwise known as ALT. More specific is carbohydrate deficient transferase, which unfortunately is not available in many labs. You can check for B12 and folate, magnesium, phosphorus, bleeding times such as PT-PTT because vitamin K may be low, or stool guaiac. And then importantly, elevated bilirubins. If you not only have a transaminitis, but bilirubins are now elevating, you're maybe heading for cirrhosis. Elevated bilirubins with a normal SG and OT and PT may be seen if the liver is burning out and it can't produce many transaminases anymore. But of course, you're still going to have the bilirubin load. And you can examine amylase in pancreatitis. For people who inject drugs, it's important to look for signs of infection, look for elevated white blood counts, look for, and always screen if you can for the sexually bloodborne diseases, hepatitis B, hepatitis C, and HIV, or uncommon infections. For substance use disorders in general, indices may include signs of malnutrition, sexually transmitted diseases, which are indicative of higher risk behaviors, and again, Hep B, C, and HIV, and tuberculosis. So I've given you an earful. Let's talk about our case vignette. So our patient bill was maintained on buprenorphine naloxone, name brand Suboxone, and provides a urine drug screen positive for opiates and buprenorphine. Is this expected for somebody on buprenorphine naloxone? I think I have the answers next. So these are the possible answers. What is the correct answer? A, yes, because buprenorphine is a semi-synthetic opioid. No, UDT should be positive for bup only. C, yes, because naloxone is an opioid derivative. D, yes, because buprenorphine will metabolize to opioids. And no, buprenorphine should have metabolized completely to opioids. So I think I'll give you just a minute here to pick your answer. We should have music here. And the correct answer is no. The UDS should be positive for buprenorphine only. Now, why is that? First of all, buprenorphine is not a semi-synthetic opioid. It's a full synthetic opioid, and so is not detected in the opioid screen. It would require a special test for buprenorphine, which especially in those in a buprenorphine clinic, you should always include that as part of your panel. Buprenorphine will not metabolize to a full opioid. Naloxone is not an opioid derivative, and if we look at our metabolism screen here, I added on the bottom that buprenorphine only goes to norbuprenorphine and does not go up to the opioids. And that the opioids, the best detected of which are codeine and morphine and 6-MAM, do not metabolize to or from buprenorphine. Naloxone goes to naloxone 3-glucuronide. So we have this positive for opioids and for buprenorphine. What do we do next? 1, we can ask the patient what happened. B, discharge the patient. C, raise your patient's bup-nal dose. D, begin to taper your patient's bup-nal dose. And E, repeat the lab test. And the answer, in my opinion, and most of my colleagues' opinions, is next is do the simple thing. Instead of testing, instead of taking a knee-jerk reaction, ask the patient what has happened. Often the patient will tell you a story that makes further testing unnecessary. He may say, yes, I had a headache and I decided to take a Percocet for my friend, or I've relapsed to heroin. And then you don't really need to go further. You can take his word for it. Now, if he says, I didn't do anything else, then you try to have to explore it a little further, and you might repeat the lab test. So, in conclusion, in the result likely, in this case, your patient says that he relapsed. The result, if you didn't ask the patient, would support heroin or codeine use. And here I explain why poppy seed sometimes can give you a positive. It's actually poppy seed cake is the highest density of poppy seeds, more than poppy seed bagel. You obtain more history to help with the insight motivation and assess cravings. And you also check your state prescription monitoring program. What's that? In each state, there's a prescription monitoring program, which allows you each time you prescribe a controlled substance to make sure that your patient is not accessing other sources of scripts, such as you could access the PMP and have found that actually he had gotten a script of Percocet from somebody else, which would then give you fodder for a therapeutic discussion. Now, if your patient says that he has relapsed, he's had craving, you probably would consider raising the dose of buprenorphine naloxone at that time if you're not already at your clinic's maximum dose. And even if you are, you want to make sure that your patient has been adherent to it, hasn't exposed himself to unnecessary triggers, people, places, and things, and unnecessary stress. And these are the references that I've included at the bottom of the slides, as well as some good, especially like number 3, very nice review articles. And I want to tell you a bit about the PCSS mentor program. I want to make you aware of these resources. The PCSS mentor program is designed to offer mentoring assistance to those in need of one or more interactions with one of our colleagues to address clinical questions. You have the option of requesting a mentor from our mentor directory, and we're happy to pair you with one. To find out more information, please visit our website, PCSS-MAT's website, using the web link noted on this slide, which is at the bottom there. And there is no cost to this. And if you have a clinical question, you can ask a colleague. You don't necessarily have to be paired with a mentor. It's a simple and direct way. We also have a very nice listserv, which allows you to, if you join that, allows you to get a lot of support from various colleagues. And then finally, this is a list of the consortium that is involved in the PCSS program. PCSS-MAT and PCSS-O for opioids includes a coalition now covering greater than 1.1 million providers, and it allows us really to try to provide training to the broadest number of people involved in dealing with substance use disorders.